Thank you. So, welcome, Marla. She's our speaker today. Marla is a licensed clinical social worker and certified healthcare ethicist with over 30 years of clinical experience in hospital social work, palliative care, hospice, and end of life support. She currently leads palliative care services with Gallagher Home Health Services and Gallagher Hospice, working closely with patients and families around advanced care planning, ethics, caregiver support, and serious illness care. Marla has also facilitated support groups with Cancer Bridges since 2016. Outside of work, she enjoys time with her husband, her four-legged family members, and dancing. Thank you, Marla Caplan, for being here today.
Well, thank you. And I'm glad to be here and certainly very familiar. I've been with Cancer Bridges facilitating support groups since I think it's 2015, 2016. It's been quite a long time. So I recognize a little bit here. I'm glad you guys are here. I know Lisa had said, to hold questions until the end. Sometimes I'm a little interactive, so I might even ask you some things along the way. And as long as you're not giving out your personal stories, we're okay with that. Um, so let me actually start off by asking anyone, what do they think palliative care is? Just kind of get a grounding level as to where, like a starting point of what you guys all think it might be. And anyone, if you're comfortable answering that, I'm okay with them unmuting and,
Yeah, that should be fine. If they want to unmute or throw it in the chat, either way should work.
oh yeah, you could throw it in the chat. I didn't see the chat. Put the chat up. You guys are a shy group today, huh? All right.
I
Well,
was told that it was a doctor that will help you comfortably get through your journey of going through chemo or after chemo, but it's not hospice where you're, you know, going to meet your maker. They said it's just to keep you comfortable and to help with some symptoms you have. That's what I was told.
that's wonderful because you are spot on with that. That's about exactly. So someone has definitely given you some good information. So it's a great starting point for us. I like to, in order to know where we're going, we always have to know where we come from, right? So I like to throw in a little bit of history and things as to where we're at with the confusion of palliative and hospice and what they mean. And I'm going to talk about both services in detail. So way back, I've been obviously in this for quite a long time, and way back in the early 2000s is when a board certification came out for physicians, and that board certification is hospice and palliative care. So it's a board specialty that physicians, carry, like a cardiologist, like your oncologist, or an orthopedic, or whatever specialty we're looking at. So it came out in the early 2000s, and in around 2005, the National Hospice and Palliative Care Organization came out and publicly endorsed this certification. So what happened from there is, hospice is always a word that people are a little bit scared of. So every hospice, and I can't say 100%, but I'd probably be willing to put 99.5% out there, took their name and they became ABC, hospice, and palliative care. And we have created this merger of hospice and palliative by doing that. And so even in today's world, with everything I do, I come across it all the time. Physicians don't understand what hospice is versus what palliative might be, and all the way down the line. So, how can we expect any of us to really know if our medical professionals don't always know? So we created this so-called monster that we have, and we've been doing it ever since to try and undo it and really separate it. So I'm glad you guys are here to really hear what each is and how it can help you or any of your loved ones. So with that being said, let's talk about what palliative really is. Because I've already, as we started off, we know it's a physician specialty. So what we look at is a physician specialty that looks at symptom management. period. Aggressive, out of the box symptom management. What can we do and what kind of recommendations can we make to help, help you have better days, help you feel better, help manage those symptoms that you might have? So if we're looking at somebody with a cancer diagnosis, a lot of times people will say to me, well, why would I want to see that physician? How is that different from what my oncologist does? Your oncologist is going to manage your cancer. It's going to manage the disease process that you see that doctor for. But what happens to all of the things that we feel and all the symptoms that happen, one, from the cancer itself, but two, even from the treatment? So when I say the symptoms, I'm talking about things like the neuropathic pain, the numb tingling feeling that you might have in hands and feet, the loss of appetite, the loss of weight, the inability to sleep, the shortness of breath, the nausea, the metal taste in your mouth, all those kinds of things that can happen. Those are a lot of symptoms from the treatment, but we also get the symptoms from the disease too, where, just not feeling good or achy and in pain and tired. I mean, there is a real symptom of pain that is a quote unquote cancer pain. And bone cancer and bone pain is probably one of the most severe. So we work hand in hand with all the other specialties, and especially with internal medicine. That your PCP is basically your quarterback to look at everything that's going on with you. And then you get the specialists involved. And, medicine today, everything is so very specialized. Even though I truly believe one part interconnects with the other and our bodies do work together, our specialists need to work together. And that's where the PCP quarterbacks it all. So we work with every specialty out there in the PCPs to really say, okay, what are we going to do to help you feel better? What kind of suggestions can we make? What happens a lot of times is people see us as a team. So they think that we are actually a quote unquote level of care that you're admitted to, which we are not. Palliative is truly just a consult specialty service that is led by the board specialty of the physician. But we come as that team because in order to really manage your symptoms and help you feel good, we have to look at every aspect of your life and every facet of things that are going on. So we have the physician, that leads it and looks at the clinical side of things, but, we're human beings and we're made up of a psychosocial, and we're, our family and our caregivers and, our spirituality, our religion, all of these things really make us who we are as a person. So, we look at it as the physician led, but we look at every other discipline because that's what makes us up. So, an example, and I like to give a lot of examples of things, is maybe someone's really, the symptom that we're dealing with is somebody's really having a lot of problems sleeping at night. So the physicians have done a complete workup from maybe the neurological standpoint and in the pulmonary standpoint to make sure they're breathing okay, and there's apnea and all these other things that might create the insomnia. But the reality is, okay, well, maybe palliative has some ideas too, because we're striking out. Well, we're going to look at that and say, oh, well, when we peel back all the layers and dig a little deeper, we're finding out, that the patient's not sleeping very well because, oh, they've got a daughter that they have been estranged from for the past 20 years. And they're looking at a progressive disease process now and saying, I want to make this right, and it's bothering me. And whether it's even conscious or subconscious, that's what's keeping them up at night. So where do we bring in the social work? We bring in the spiritual team, all these other components to address that need, because that's part of it too, to help somebody feel better. So it's not just that clinical component. But what we also do is we look aggressively out of the box in managing some of those clinical symptoms that you might be feeling. So again, some of the examples that I might look at is, somebody that is having some of that pain, some of that neuropathic pain, or even just muscular pain of some sort. And they're just feeling washed out and tired and fatigued. There's a medicine, and again, this is an example, and I'm not a physician, I'm not telling you to go ask for it. But something that we might look at is a medicine that's called duloxetine, and that's the generic for Cymbalta. And Cymbalta came out as an antidepressant medication. However, it is now also FDA approved to treat musculoskeletal pain, neuropathic pain, and it's an energizer. So from the palliative perspective, sometimes we'll look at that medicine and make that recommendation, and not because somebody might be depressed, but because of the pain and the energy levels that it might help with. So it's kind of that out of the box type of thinking and looking at things. Sometimes another example might be taking it out of a cancer diagnosis type of thing, but let's say you also have maybe a congestive heart failure. So you're going into an active failure, which means your heart is filling up with fluids. And every time, what does your cardiologist or your PCP tell you is go to the ER. We have to get you on IV diet, and get you on IV Lasix to take that fluid off of you so that we're, controlling the fluid levels, and you're also breathing better because it will also cause that shortness of breath. But, from a palliative perspective, we might say, you don't necessarily have to be on IVs, but, we can double your Lasix and add another med called metalizone or something along those lines and keep you at home and just monitor it with some labs. And we're going to treat that symptom really quickly, get you breathing better, get the fluid off of you, and save you from having to go to the ER because nobody ever wants to go to the ER. So that's kind of some of the things that we look at. The other really important thing to remember with palliative is we can see anyone at any age, at any point in a disease process. It doesn't even equate to end of life. If somebody has some complicated symptoms and they're not really feeling well, and we want to do something to manage that, a palliative physician and a referral to a palliative service is a great idea. Again, with examples to kind of put it into perspective is I look at it as, let's just say there is a 25-year-old that just was involved, sadly, in a major car accident and has all kinds of broken bones and maybe had a drop lung and, some other things going on. Obviously, we've got a lot of symptoms and a lot of pain and a lot of issues that can be managed. And they might say, oh, wait, palliative might be a great consult for this person. But by no means are we talking about someone that is even at an end of life. We are not always that bridge to end of life care. So, I don't want people to be scared of what palliative is because it's really a supportive physician consult service to say, how can we help someone feel better and have better days? How can we better manage whatever they are going through? It might be chronic disease, it might be an acute onset trauma, and it might be a long-term disease and at any stage of it. So that's kind of what we look at, from that consult service, from the symptom management perspective. But one of the other things that we do in palliative is we do a lot of the goals of care conversations, and again, bringing in the team perspective because social work and spiritual counselors and, some of the other disciplines really are very comfortable doing it, sometimes much more so than what a physician might be. But a palliative physician has no problem having this conversation too. So when these things are happening, and by goals of care conversation, what I'm talking about is really, what is it that you want for your own treatment? And I suggest these things, and that's another whole topic is advanced directives, and we can certainly go into some minor details if there's questions on it, but that's another whole talk. But, when you want to make decisions, it's your body and it's your life, and there's no right and wrong answers to any of it. But for us as a healthcare professional, we want to know what that is so that we can give you what you want and we don't give you what you don't want. And the only way to really know that is to sit down and have that conversation. And the best time to do that conversation is when you are not in any state of crisis or going through something traumatic. You do it when you're really thinking very clearly so that you can make rash decisions. And will that decision change? Absolutely. If you talk to someone who's 25 years old, what they would want might look very different from somebody at 40. It might look very different than somebody at 55 or even 65. As our needs change, as our values change, as we age, as different things happen with our bodies and, our lives, our goals will change too. But the most important thing is that we want to know what those goals are. And sometimes, they give this to palliative, which is why a lot of people also think we are that sliding board springboard into hospice is because we will do a lot of those goals of care conversations. We're very comfortable in talking about it. It is a sensitive conversation. It's a very difficult conversation to have. No, in this country, in the United States, death is very taboo. And so nobody ever likes to talk about. And goals of care is not always about death, but it might be decisions if you were faced with a life-threatening need. So, it's one of those things nobody wants to talk about. So we do it all the time, and we do it from the multifaceted, different disciplines and kind of really drill down. What does it mean? What are the things you might want? And helping you to kind of see what decisions what decisions you might want to make. And again, there's no right and wrong answers to it. It's really what somebody wants ultimately. So, and I'm sorry, I'm going to stop for a second because I just saw a question in the chat of what is the name of the med? So the one for the pain and the energy is Cymbalta. The generic name for that is duloxetine. Yeah, it's certainly something to go back to your doctors and ask them about for sure. Again, physicians can prescribe based on everything going on in your body. I can't do that. I wouldn't attempt to do that, but it's certainly something worth asking about.
Yeah, because the gabapentin doesn't seem to be touching it. So,
And yeah, and so you bring up something again out of the box, trial and error of things. We do it a lot where we'll say wean off the gabapentin because it's really not helping, and let's start duloxetine and see what it does for somebody. For sure. So it's, and no every med has a side effect. There's no free lunch. But sometimes one thing's going to work better for one person and something else might work better for somebody else. Every body is created so powerfully different. But sometimes if we go into this tunnel of this is what I prescribe and this is what I do, we're never going to see that. And that's kind of the other side of palliative is out of the box. Again, the aggressive symptom management of what we can do. So, going back to that goals of care conversation, really, the other thing I will say is, you think about a physician takes that Hippocratic oath to do no harm, but they're taught and they're drilled to treat, and cure, cure, cure. And sometimes maybe we have a disease process that we can't cure, but we can certainly treat and we can certainly manage symptoms. And so, having that conversation sometimes goes against what a physician really wants to talk about. It kind of is out of their wheelhouse. They're not comfortable with it. Plus, it might take a long time. I have no problem sitting down with someone and having this conversation for an hour, 2 hours. I've even been with someone for 3 hours talking about these things because it's your body and there's questions and they're not easy decisions. And sometimes you don't even make the decision, but just the questions to understand to make a decision. Takes a lot of time. So that's kind of really what palliative is, what we look at, where we come from. Again, don't corner it. It's just really a physician specialty that comes with a team approach so that we can look at symptoms and help someone feel better. But with that said, so then how does hospice differ a little bit? And we can talk about that. But before I move on to hospice, is there any other questions about palliative in itself? Okay. All right. So hospice. And again, one of the things I said in the very beginning is a lot of people are very afraid of that word. In history, you got to know where we come from to know where we're going. So I think of hospice when somebody says to me, Marla, what is hospice or what is it about? First thing I'm going to do is hospice is about living. Hospice is not about dying, it's all about living. And it has changed so drastically from when it first came out. So, I'll go back. I like to start with if you think about Hippocrates, way back, how many hundreds of thousands of years ago? He was really our first palliative physician and really kind of the thought of hospice because his motto was treat often, cure sometimes, but comfort always. And that's kind of where I was with palliative. But that leads into hospice because it's about the living side of it. So we really started hospice. It started years and years and years and years ago back in England, actually in Greece. And then that was the mother of hospice, the grandmother of hospice, and then the mother of hospice was in London. But it came to the United States in the late 80s in Connecticut was our first real hospice. And it was approved under the Medicare benefit it came in the 70s, but it came under the Medicare benefit in the late 80s. And at that time, the Medicare benefit for hospice basically said, and this is where the fallacy comes in of what people are so afraid of, the Medicare benefit for hospice was 5 days in a lifetime benefit. So when somebody was really kind of recommended to go to hospice, or that word was brought up for somebody, we absolutely knew, yes, we were probably at a very end of life, like last days of somebody's life. That whole vision of when they curl up into the fetal position, they're really not responsive, they're not talking, they're not walking, they're not eating. That is when people started with the hospice benefit and said, okay, because we got 5 days in a benefit, we want to use it wisely. And on top of that, you went to a hospice. There was a designated unit in the hospital or somewhere that you went to so that they could manage you for those last couple days to try to do everything to really keep you comfortable. Well, let's fast forward now. We're in 2026, and so much has changed in between all of that. So, Medicare and CMS recognize first off that you're not going to do any good in the last 5 days, because if this service is really about comfort, which it is, and it's about living, then we need to give that opportunity to do so. So first off, they've changed the coverage of it. So no longer 5 days, but we actually have unlimited number of certification periods in hospice. So if you have Medicare, and I know I'm kind of jumping around a lot because there's so much to it, but if you are of Medicare age, or you have a disability that you have Medicare for, basically, once you would elect to have the hospice benefit, even if you have an Advantage plan or anything else, that hospice benefit automatically goes to Medicare Part A, and they pay for everything in full. And where I was going with this is the unlimited number of benefit periods. So it's not necessarily a limited number of days or months or anything of that nature. And if you have a commercial plan, so if you were actively working and you have, a regular, Blue Cross plan or whatever it might be, there's usually a hospice benefit in that too. And it follows the Medicare benefit for the most part. But it's just a matter of getting all the authorizations for it. And honestly, for them to deny that would really be a horrible thing. And I've yet to see it. So the hospice benefit really is, it has to read as we have regulations that we have to follow. So that regulatory guideline basically says if somebody is facing a life-limiting illness, we would expect, if the disease continues on a normal course, a limited life expectancy of 6 months or less. Well, we don't have any crystal balls. And for any physician that wants to tell you a time frame, they're shooting from the hip. They don't know. We have a lot of signs and symptoms that we can look at. And, the doctor that I work with every day will always tell you, he'll say like more than 50% of his boards were on prognostication of things like this. But the reality is, again, we're human beings, and it's not up to the physicians. It's not up to anybody but you and your higher power, whatever that might be. People know how they feel. They know what they want, what they don't want. I've seen everything from somebody that was really strong and healthy and not expected to have an end of life that ends up passing away. And I've seen somebody that, the physicians are all saying, well, we don't think she's going to survive much more than a couple of days. And here we are a couple months later. And I've seen, from even working here with Cancer Bridges, I have folks that I've talked to that, one in particular comes to mind. And, the physician said, you go get your affairs in order because I expect about 3 weeks. And that was about 14 years ago. So we don't always know, right? And that's the beauty of hospice. It is actually a level of care. It is something you are admitted to, and it is a benefit. So when we have a benefit, we have that entitlement of what that benefit reads. And first of all, having Medicare is an entitlement and a benefit. And so hospice is one of those programs under it. So if somebody qualifies for it and wants to elect it, then we need to make sure we give them what they need. So what does hospice do? First off, we talk about hospice. All of hospice is palliative, but not all palliative is hospice, as I talked about. So we have this big palliative world of care that we see anyone at any age. But a subset of that within that big circle is hospice, because they will do symptom management all day long, and they probably are the best at it. They manage symptoms like nobody's business. But it is about living, because they are also charged with doing everything to make life wonderful for whatever time frame that might be. And we don't know. So we put the limits of 6 months or less if a disease continues on a normal course. And again, everybody is different. So what's normal for one person might be very different from somebody else. We don't know that. So we just treat symptoms and we help people feel better all day long is what we can do. But in order to manage that life process, to make things easy, is hospice now is charged with, oh, we're going to pay for your medications. We don't want to complicate something where you have to call in and get a refill and go to the pharmacy and, find the co-pays for it. Oh, no, hospice is just going to pay for it and deliver it to you. No more fighting with the insurance companies on any kind of equipment that you might need. If you need to have a hospital bed, if you need a wheelchair, if you need oxygen. I mean, even if something as simple as like those over-the-bed tables like you always have in a hospital, you know what? Hospice just pays for it and brings it to you. No more battles, no more worry about how we're going to get it. If you need it and it makes life easy for you, they pay for it and bring it to you. So they're paying for medications, they're paying for equipment, they're paying for supplies. So if somebody needs the chucks on the bed, if they need diapers, if they need lotions or wipes or any of that kind of stuff, no more of, oh my God, managing my budget. No, we're just going to pay for it and we're going to bring it to you. So you don't have to worry about getting to the store to get it. It's really just looking at every aspect of somebody's life as to what are their needs going to be, and kind of, thinking that through and being proactive to say, we're going to manage it and we're going to pay for it and we're going to make life easy. Hospice will pay for in full under that Medicare aid benefit, all of the meds, all the equipment, all the supplies, all of your team. And, a couple benefits to all this is that, let's just say, if you were on a home health service, you have to be homebound, right? You're going to get service because you can't get out to see a doctor. But hospice takes that all away. You don't have to be homebound. You want to go out shopping with your daughter, your best friend, go. You want to travel. You want to go to the beach, your family reunion in another state. I mean, whatever you want to do, hospice supports you to be able to do that. So, if you were traveling, let's just say, you want to go to Florida for a couple weeks, hospice will actually contract a hospice agency to where you're going so that you are not there without any care or any service that you might need. And you go and you're covered. And then when you come back, you come right back under the care. It's like, there's nothing else that does anything like this. They're just really fabulous. What are the fallacies of hospice? They say, oh, we're going to take your doctors away. No, you don't ever lose any of your doctors. You gain a hospice medical director, but you don't lose any of your doctors. What happens is a little bit different on a back end. Because hospice is responsible to manage everything, it's a billing issue. So, hospice has a little bit more control. But if you want to go see your doctor, you absolutely can go. And if it's a doctor that's not even related to what hospice sees you for, you just go and do it as if you weren't even on hospice. And an example of that might be, an eye doctor. Usually eye doctors are never related to, a heart disease or a cancer or anything like that. So if you wanted to go, then you go, and he's prescribing you meds, you have your meds. The only thing hospice, it looks at two things. So it's that clinical component, but philosophically, the other side of hospice is you have to say, I'm at the mindset now, go back to that goals of care conversation. I'm at the mindset that I want to be treated. I want my symptoms treated. I want to be comfortable, but I'm not interested in anything aggressive. I'm not looking at curative active treatments. I don't need transfusions anymore. I'm no longer wanting to take chemo or radiation or immunotherapies. Um, I try to think of anything that's even therapies, sometimes aggressive physical therapy. Those kinds of things are not within the hospice mindset. So, but having to treat your symptoms, having to make sure you're comfortable, bringing the care to you wherever you might reside is what hospice is all about. So, if you got a UTI, they are going to treat it. The fallacy is those, yeah, I've had so many families say to me, so if I get an infection or something, you're just, I go on hospice, I'm just going to lay in a bed until I die, right? And nobody's going to do anything about it. No, 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 no. You have a UTI, for example. We're not going to go through all of the rigmarole of saying, okay, let's get a urinalysis and let's test the sensitivities and let's, call the doctor and get a prescription and go to the pharmacy and pick it up. No, you know what? If it has the symptoms, it smells like it burns like it feels like it, we're just going to get the antibiotic to you and get you comfortable and manage it. Why kind of play the game? Again, um, cure sometimes, treat always, right? I mean, comfort always, treat and comfort always. And that's where hospice is about. So you get a pneumonia, we're going to give you the antibiotics. They're not going to hold those kinds of things from you. It's again, what's curative, what's aggressive in nature that they're going to look at to say, we're not going to do that. That doesn't align with hospice philosophy. So hospice, has so many benefits. I'm just trying to look at my own notes here to make sure I cover everything. So anybody can really refer someone to hospice, but of course it takes a physician and it takes two physicians to certify that you meet that criteria and get you to admitted into their care. So even if you had questions, you can have hospice come out and do an evaluation. You can have them come out and do an informational visit with you. It doesn't mean that you have to say yes, that you want to proceed. It doesn't even mean that you're going to qualify for the care. But, it does take, as I said, you don't lose your physicians because you have the hospice medical director and you have your own attending physician, and both have to say, yes, you would meet that criteria for admission. And again, because doctors don't have a crystal ball and we really don't know, they really look at signs and symptoms of everything. And Medicare recognizes that. So what they have also done is they've set up by disease process. So if it's a cardiac disease, a neurological disease, a cancer, Parkinson's, we look at everything by a diagnosis and say, okay, we look at this, and if you have A, B, and C criteria, then you would meet those qualifications for hospice. And that's how it would move forward. Now, going back to the fact that you have these unlimited number of benefit periods, sometimes someone might meet that criteria, but they actually start to stabilize, which means hospice has to discharge you. So, there's a bittersweet in that too. But again, hospice is about living. But the other thing I also like to say is you drive your bus, guys. Whether it's in hospice or anything else in the healthcare system, you drive your own bus. It is your body and your right to say what you want and what you don't want. You have a right to refuse things if something doesn't sound right. So along with that, your bus has gears. So you could be in, low gear, high gear, but it also has reverse and it also has brakes and it has a door that you let people in and out that you want. You kind of take that analogy to anything that you're doing with getting any kind of treatment or any kind of care for anything. And you got to think that way. This is my body and my boss. And I'm going to and ask the questions. Doctor, why are you recommending this? What does this mean? I don't want this. I do want that. You have a right to say all those things. So with that being on hospice too, is if you change your mind, you're allowed to revoke from care. Just because you would say yes to hospice doesn't mean it's written in stone forever. We might have to discharge you because you do well, or you might say, you know what, I think I do want to go back and try that treatment and I'm going to come off hospice. And you have every right to do that. And guess what? You know what? 6 months down the road, if you want to revisit that, you can go right back on. You can come on and off. It's not like a do or, one time thing. So I think that's important to know because a lot of people don't realize that you have that right to say I do or do not want and to change your mind. You always have the right to change your mind. I can't stress that enough. Um, and the last thing I want to just talk about with hospice is, again, I kind of said it's wherever you are. So whether you're in your own home, whether you're in a family member's home, whether you're residing in some sort of a facility, hospice is going to come to you. They're going to bring the care to you. So when do things usually happen? Something, you're all of a sudden getting nauseous. You can't sleep. Something's happened. It's usually, what is it? It's usually 2 in the morning, 8 o'clock at night. It's usually after those regular business hours, right? So hospice is 24/7. If you've got symptoms and something's going on, you have every right to pick up the phone, call your hospice and say, hey, I need help. I need a nurse out here. Um, and that's what they do. Instead of calling 911 and getting in an ambulance and going to the ER, your nurse comes to see you and they can make so much happen in the home without having to leave it. So it's comfort and it's living and it's enjoying whatever life you have for, again, could be a year. We don't know. We don't know. I've seen people on hospice a year and a half, almost 2 years. And it's because, again, every person's so different in how they go through things. So don't ever let anything scare you with that. You drive your bus, you do the things that you want to do, you call the shots and ask the questions. But with that being said, too, just lastly, I want you to also understand there's different levels of care for hospice. So what we see every day is what we call routine care, where usually it's like your nurse that might come out a couple times a week, an aide that might come out a couple times a week. And of course, if you're symptomatic and something's needed, they might come every day to see you. But we also have a nice respite level of care, and that's more for your loved one or your caregiver. God forbid there's an emergency or something happens, they can actually take the patient to a skilled nursing facility. They will pay for the transportation. They will see you there for 5 days, up to 5 days, and then they will pay for transportation and bring you right home. So it's kind of a peace of mind too that, someone's not locked into something if God forbid we need to attend to something else. And then there's also what we call continuous care. Some people call it crisis care. Because what if we have some symptomology going on that we can't get managed? Go back to what's the hospice 101 is comfort and managing those symptoms, right? So that's our first goal is to making sure you're having quality of life and comfort of life. So if there's some kind of symptom that's out of control, hospice can be in that home up to 24 hours and do whatever they need to do to get something managed. And you know what? It might take a day or two, and then things go back to some normalcy. Um, that's kind of what they're there for, just to be there for every little thing along the way that you need them for and want them there for. And then there's lastly an inpatient care. And that's what a lot of people think hospice is, but really it's very, very rare that we use that. It's usually when someone is in a hospital and probably could not survive an ambulance ride home, and we know their time is very limited. We would put them on inpatient level of hospice, usually in a hospital, so that they can be attended to 24/7, and manage and keep them comfortable. But there's very, very strict criteria, so most people don't even see that. But that's kind of the levels of care, the coverage of care, what we do, the players involved. It's a wonderful, wonderful service if, in fact, you're at that point in your life that you might need it. But palliative at the same time is going to manage those symptoms as well without it being an admission to care, for anyone at any age. So with that, what kind of questions does that bring now?
So I'm curious about the administration of the serious pain meds like morphine. Is that something that only the hospice nurse or aide can do, or can the caregiver do that too?
So it's a really good question. And there's a couple of things that went through my head when you were first asking, not realizing what the real question is. But I do want to say first off, that's another one of the fallacies of hospice is, oh, they're just going to give you morphine and snow you out. And that's not, in fact, the case. As a matter of fact, you start with Tylenols or something light because nobody ever wants to be snowed out. We want to manage symptoms, but not make you sleep away. And morphine is actually a really nice med that does, I mean, it takes a lot of morphine to cause you to not be able to breathe on it because actually the way it works is it opens up your arteries and helps you to breathe a lot better. But what hospice does is to get to the root of your real question here. What hospice does is they have what they call a comfort kit or an emergency kit. Everyone calls it a little bit different. And that kit is usually when you're admitted into hospice, those kits are ordered and brought into your home. So it's really nice. They have tools on board, things that we can't do in home health and other services. And there's a lot of different meds in that kit that will treat just about every symptom that you could think of. So, if it is pain, if it is nausea, if it's shortness of breath, if it's, oh God, constipation, whatever that symptom is that there's a med in that box that's probably going to be able to help better manage it. So, yes, if in fact somebody is having some severe pain, there is a morphine, and sometimes it's, done in an oral, liquid dosing or different types of administration. So it's not necessarily through a shot. So yes, the nurse you might call hospice and say, I don't know what to do. And, my loved one's having so much pain. And they're going to say, well, you know what, go into your emergency kit and pull out that syringe that's got the purple top and administer this, and I will be there within 30 minutes. So yes, in that fact, the caregiver can administer it. And there's a lot of times we want our caregivers to administer meds. Now, clarification on caregiver as I'm saying this, if caregiver means your family member, yes, they can do that. If you have a paid caregiver in the home through an agency, through a home care service, that is beyond their scope. They are not allowed to administer meds. So kind of a distinction there. If you're paying for the caregiver to come and take care of you, they're not allowed, but your own family member as a caregiver or a friend as a caregiver is certainly encouraged to do so. Does that help?
Yes, thank you.
Mm-hmm. Other questions?
Well, I'll go ahead with my second question. So
Sure.
I did not realize that you can get service so frequently with a nurse. I thought that that was limited to, say, 2 days a week or whatever.
Oh, no, 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 no. So a good hospice, because there's a lot of hospices out there, but a good hospice is going to be able to change their plan in the snap of a finger. You might be, so you're set up with a plan of care from the day of admission saying, okay, here's what we're seeing. And you know what, from where you're at right now and what's happening with you, we might send a nurse out 2 times a week. But let's say into week 2 or into week 3, and you start developing a wound or something that needs dressed every day. That nurse is going to come every day, and they're going to change that care plan. Hospice is one service that's really, really nice that we don't see very often, where they actually are required to meet as a full interdisciplinary team. Your hospice medical director, your nurse, your aide, your social worker, your spiritual counselor, all of the above. They have to meet once every 15 days. And they go from every discipline to say, hey, here's what I'm seeing. Here's what we're working on. Here's how she's doing from my perspective. Because we all see something very different from our specialty and our profession that we come to the table with. And so from that, we kind of look at that care plan and what changes need made. What do we need to change, decrease, add, whatever. But at the same time, those nurses, and I'll go back to, that seeing the physician. A lot of times I'll say to somebody, the question becomes, why do you want to go to your physician? Because the nurses are so, they're so tight and managing so much that your physician probably knows more of what's going on with you than if you were just going to see him once a month or once every 3 months on an exam table. Um, so I see I mean, these nurses, hospice nurses, are constantly on with their medical director. Hey, I'm here with, Mrs. Smith today, and here's what's happening with her. And, we need to order blah, 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 or what do you recommend to do for this symptom I'm seeing? And I mean, they get it like that, and it's meds are delivered, in emergency immediately. Um, Change the care plan. I need to be here every day. I need to implement my continuous care, what have you. They can change that up so quickly. So just because initially you might only need somebody 2 days a week, that can change in a heartbeat. It's a good question, for sure. And the other thing is I'm talking about the different disciplines too. I keep calling it spiritual care because really it is a spiritual care counselor that is by regulation. It doesn't necessarily mean that somebody ordained. It does not have to be an ordained from a specific religion. Religion and spirituality are so different. But both might play a big part in somebody's hospice care. But the requirements are spiritual counselors. So they really are very non-denominational. But if somebody does want, whether it's a priest or a rabbi or what have you, we would certainly work to get somebody to come into your home and visit or set up a visit some way or another. So we want to address what your needs are all along the way. On top of that, the one other thing I really didn't mention about hospice is the volunteers. Hospice was built upon the volunteers, so it is required that we do so much volunteer work. These volunteers might come and just sit with you. They might actually, they might be volunteers that are in the office doing things, but we might have volunteers that come and do pet therapy, music therapy, art therapy in the home. Sometimes it's, hey, I'm at home with my loved one, but I've got to go to work every day for 3 hours. But you know what? The volunteer comes 3 days a week for those 3 hours so that she's not alone many days. I mean, we can get creative with what we use that for. With good questions. Keep them coming.
Well, I have another question about the bed.
Mhm.
So I always thought that once you get hospice, the bed comes. But I'm feeling like no, it depends on the circumstance. Can you just
It's up to you. So it's very common. Most people want that hospital bed. Um, But number one, you might be comfortable in your own bed and not need, and you might be very well able to transfer in and out and doing things. You might not have room for a hospital bed. Some people set them up in the middle of a living room or in the middle of a kitchen sometimes because there's nowhere to put them. It's what is your comfort and what is your need? You don't have to take it. It's there for what you'd want it. You drive that bus all the way around, even with all the equipment. So it's really, and there's things that, hospice will bring out that you wouldn't even think about, like even the lift chairs they do, or, if you need, like I said, that over the bed table, wheelchairs, transport chairs, walkers, canes. Medicare allows you one ambulation device that they'll cover in a year. Hospice will bring it all. But what do you want and what do you need is the real question. Yeah, more questions. Anything about palliative? Any questions on the palliative care? Have any of you guys has anyone actually seen a palliative physician in consult?
I am working with a palliative doctor right now, virtual, because that's how she does it. And like I said, we're experimenting with the gabapentin, but it's not helping at all. And that's why I was wondering, what the next steps were, because I go to my oncology appointment this Thursday, and I'm going to talk to her about the palliative doctor,
Hmm.
just to see, and they even suggested using acupuncture. I've gone through 3 sessions in that, and so far nothing. I'm just very impatient. Um, self, I'm independent woman, likes to get stuff done myself. So I know I went
Good
through the
for you.
12 treatments, the 6 months of chemo. And I know it's going to take that, if not longer, for everything to get out of my body. But right now it's the neuropathy that is really bad. That's why they're trying with the gabapentin. And put it short, I can't feel my hands or feet because of my neuropathy, and my job is nothing but on a computer 8 hours a day. So that's, kind of not doing well.
Yeah.
So,
And the acupuncture, interestingly enough, the way acupuncture works is it's not the needles that go in. You know how they turn them?
mhm.
The turning of it activates, it's supposed to activate and turn off the pain sensors.
Right. Well,
How it's
I don't
supposed to
have that.
work,
I've
but
knock on wood, I really never had the pain. I've just had like the numbness. And it
Mhm.
would start as the tingles, like, going into my 10th treatment. I told my oncologist, she's like, you know what, we're going to take that one medicine out of your cocktail because you only have 2 more sessions to go. And you've had, 10 treatments of it instead of the 12. And then it's to the point now, like I says, my hands, I can't feel them at all. And I'm right hand dominant, and my right hand's my worst.
Sorry.
Like I said, I drive to my mom's, who's maybe like 5 minutes away, because I go do her laundry, do housework and after her. But I
Mhm.
take back roads because I don't feel comfortable. I can feel the pedals, but not, feel the pedals, if that sounds weird. And like I
No, I
said,
know
just
what you.
eating dinner, I'm holding my fork, all of a sudden, it slides right down, onto my plate. I can't even tell. So it's to the point where it seems like it's getting worse instead of better. So
So
that's why I'm trying to explore different things.
yeah. And a couple of things that come to my mind with that is,
Mhm.
obviously the Cymbalta for sure. But, even trying again, we come from all the different disciplines, right? Everyone brings their seat to the table. Um, I'm thinking occupational therapy might have some things to help, like some of the adaptive equipment, so that you might be able to do some things with grabbing things, or, I mean, even therapy to move things, and they might be very helpful in any of that
Right.
PT
The
and
month of
OT.
December, yeah, the month of December they did sign me up for PT, so I went, and what she did was she's like, just do this with your hands, and gave me all these printouts. So of course the holidays were coming, Christmas, New Year's. Went to go back in January. They're like, your script expired. I'm like, oh, I only had 2 sessions. I didn't know the script expired. But long story short, I told the PT, I said, I've been going on YouTube and doing different things, and I even have a red light glove that I, switch while I'm watching
Mm-hmm.
TV. You put that on at night. And I've been doing that. And like I said, the acupuncture, this past Friday, he did it like in the web of my fingers and the web of my toes,
Mm-hmm.
and like did this bone water stuff. And he, texted me on Saturday and says, how do you feel? I'm like, no different. He's like, okay. So, and of course, acupuncture isn't covered under insurance. So that
Yeah.
doesn't help. But yeah, I've done, and if I do have like an old like mayonnaise jar or anything, I will keep it. And my husband will go to recycle it. I'm like, no, no, no. He's like, what? I'm like, that's my practice. And my water bottle has a twistable lid that
Uh,
I have on the straw,
you
but
don't
I'm
use
using
it,
this
you
one
lose
to
it.
keep, yeah, to keep doing, and
Mm-hmm.
I try to do as much as I can through the day. Like I'll be sitting in the car, wiggling my fingers, watch TV, do my exercises. And it's just to the point where nothing's helping. So
I'm
it's
sorry.
getting very discouraging. Like I said, got through chemo, fairly well, the treatments, and now it's bam.
And the other
This.
thing is, God forbid you need to go through more treatments, and all of you guys, one of the things that we know that sometimes the physicians don't always know is the icing techniques. When you're going through treatment, icing the head, icing the hands, the feet, to stop that neuropathy from coming.
I read that after I was done with all my treatments in October, because I did have cold sensitivity, because they said like if you go into the refrigerator, even to make my husband's lunch in the morning, like to get lunch meat, just to take it out of the packaging, was like, oh my gosh, this is so cold. And and I couldn't touch anything, because it was so cold, but they never said anything about that, and which I never knew about until after I was done with all my treatments. So,
I just want to let you know we have 5 minutes left. Is there any last questions or comments
nope.
for Marla?
All right. Well, I'm glad you guys came. I hope this was helpful for you.
Yes. Thank you so much, Marla. We really appreciate your time
Absolutely.
and effort and just all the great information you shared with us. And I know the regulations are constantly changing with hospice and palliative care. So
They
it's
do.
always good to hear up-to-date information.
Yeah. And I'm happy to, I mean, if there is questions and you want to bring them back to Lisa, I'll be happy to answer, on an individual basis too, anytime.
Yeah, absolutely. I can forward any messages to Marla and she can get in touch with you. So yes, thank you.
Well, thank you for having me. It was nice to meet
Great.
you guys.
Thank you.
All right. Bye-bye.
Bye-bye.
Bye.